Hello, everyone, and welcome to today's AC Forum webinar, Ask the Experts. We did one of these a while back, and we had such good, turnout, and it was very well received that we wanted to do another one. So today I'm pleased to moderate with some of my good friends and colleagues um, this Ask the Experts session. I'm Arthur Allen. I'm a clinical pharmacy specialist and anticoagulation program manager at the VA hospital in Salt Lake City. I have on the panel today the AC Forum current president, Allison Burnett, who's the lead pharmacist on the inpatient antithrombosis stewardship program at the University of New Mexico. We have the president-elect, incoming president, Jeffrey Barnes, associate professor, a cardiologist and vascular medicine specialist, researcher, and all-around nice guy from the University of Michigan. We're pleased today to have one of our AC Forum partners, works a lot with us on the Centers of Excellence, Tara Lech, Director of Anticoagulation Services and Stewardship, the Anticoagulation Stewardship Program at Beth Israel Lahey Health. We have another one of the AC Forum board members, Anita Rajasekhar, my favorite name in the world to say once I figured out how to say it properly. Professor of Medicine and a hematologist, University of Florida. And we have another friend of the forum, Bethany Samuelson Bannow, a hematologist, although very focused on women's health stuff. So I'm going to refer to her as a hematologist from the Oregon Health and Science University. We have a great team today to discuss the issues that have been pre-submitted. If you registered for this, you saw that you had the opportunity to participate and drop in questions, those topics that you wanted to get discovered or discussed. Because of that, we're going to go from our usual format of having a Q&A question box for the audience. We're actually not going to take audience questions today. We want you guys to sit back and relax, really focus on the conversation. We've vetted through lots and lots of submitted questions to come up with topics that, believe us, are things that you need to know and need to learn. So just sit back and relax and enjoy. And we are going to get into the conversation here in a moment. Before I do, I want to just say, if you're not a member of the Anticoagulation Forum, what in the heck are you waiting for? It's a great organization. Membership is free, and it will unlock a plethora of resources for you folks to participate in this growing field in. So join us today if you're not a member. And if you've never been to an Anticoagulation Forum live meeting, you don't know what you're missing. We're going to be in DC in the spring. A good time will be had by all. Have 3 days of jam-packed sessions, lots of experts to not only hear from this podium, but rub elbows with. You have the opportunity to submit abstracts, and you have CE opportunity as well. It's a truly multidisciplinary organization where we all show up as equals. Just want to give a plug for the Anticoagulation Centers of Excellence program. This is how I actually started my foray into the Anticoagulation Forum, was to help develop the program years ago. It's now been around for more than 12 years. It opens up a lot of opportunity for resources for now original content. And the Anticoagulation Forum launched recently a new website that really makes all of these resources accessible in a very intuitive way. So if you haven't checked out the Centers of Excellence program, do that. And if you haven't worked through the assessment to see if your site can be named and recognizes a Center of Excellence, you should do that as well. All right, we are going to get started. I'm going to come off screen sharing here. We're going to go. I can see all of your lovely faces, and we are ready to get going. So I'm going to start the topic. We announced a few different kind of high-level topics that we would try to cover in this webinar. I'm going to start with the issue of thrombosis and thrombophilia. I think that, there's a lot of confusion around the utility of thrombophilia testing. In my opinion, it's often done by folks who don't have the expertise to know if it should have been in the first place or how to evaluate it, especially outside of thrombosis and anticoagulation specialties. And I actually often feel that there's a significantly higher risk that the result will be misused than it will be helpful in the case. And so I'm going to start with Anita as our hematologist. When and in whom should thrombophilia testing be performed? What should we do with the results of it? And how do we avoid some of the nonsense that notoriously follows and ensues after thrombophilia testing?
Thanks, Arthur. Yeah, that's a really good question. And, I always wonder, why are we doing so much of this testing? I think a lot of it is we can, right? We have the ability to test, and so why not? More is better. And so that's clearly not the case in this scenario. I think about three things when I'm thinking about thrombophilia testing. Number one, is it going to change your management? Are the results going to change your management? And in most cases, the answer there is no. And then I think about discussing the implications of the test with the patient before we even do testing. What are we going to do if it's positive? What are we going to do if it's negative? Why does the patient want the testing? And there are some reasonable, justifiable reasons for a patient wanting testing, even if it's not necessarily evidence-based. And then finally, if you decide to test, making sure you're testing at the appropriate time and the appropriate setting. So that's the sort of three big picture things that I think about with thrombophilia testing. With regards to the first, will it change your management? In most cases, it won't, because I think of Stefan Moll. He's created this really nice pyramid of risk where on one end of the pyramid, you have those provoked clots. And those are the ones where we know the risk of recurrence is quite low after treating the acute clot. So these are your clots after surgery, for example, a major surgery. So we know we're going to treat those patients with 3 months. Then on the other end, you have those patients who've had a clearly unprovoked clot. Or a recurrent clot, let's say. And those patients, we know we're going to keep them on indefinite anticoagulation. So doing thrombophilia testing and all the mess that kind of goes around with it doesn't really change my management. It's the gray area, the middle of the pyramid of risk that I think about, well, maybe additional thrombophilia testing might help me move that patient up to a higher risk or a lower risk. So those patients for me are those ones that have clots in the setting of a minor provocation, whether that's travel. I have tons of patients who say, I've traveled for 8 hours, but doc, I got up and I walked around every 2 hours on the plane, or I stopped for gas every couple of hours. Or those patients on oral contraceptives. And, to me, temporally, when they started the oral contraceptive is important. Have they been on it for 10 years? Well, then I'm really not thinking this is provoked from that. So there are these, again, gray areas where that's where I'm having discussions of thrombophilia testing. So that's one of the big things I think about before I even decide to do thrombophilia testing.
Yeah, what strikes me is that everybody seems to remember factor V Leiden. That's the only one that they remember. They give it entirely too much credit. And so, a patient who's found to be heterozygous for factor V Leiden, it's like, that's it. That's why they had a clot. I'm like, the other, 5% of the American population with that, might argue with that. So I think that what we see as wimpy risk factors, folks tend to overestimate the value of. But, you brought up estrogen. And so I want to jump over to Bethany. Bethany, can you tell us, like, coming from a women's health standpoint, do you think about this differently, or think about the value of thrombophilia testing differently in women of childbearing potential? And then I'd like to add to that as well. I often think about, well, even if it's a male, do they have a female offspring? And kind of, can you fill us down on what's real with risk to female offspring and that kind of thing?
Yeah, thank you, Arthur. Those are really great questions. So first of all, I always like to point out that when the American Society of Hematology came out with their thrombophilia testing guidelines, the only strong recommendation, there was only one, was not to do general testing in people about to go on, they say combined oral contraceptives, I say combined hormonal contraceptives, whatever. So we're not testing everybody. So that is very, very important, because there's literally probably millions of people out there with factor V Leiden heterozygous on birth control pills doing just fine. And so we don't want to be withholding that, right? In terms of somebody, thinking about, kind of two different risk areas, right? When we're thinking about contraceptives, and then I think about pregnancy a little bit differently. So in my practice, if I have a patient who is wanting to go on some kind of hormonal contraceptive and they have a first degree family member with a history of VTE, regardless of what the testing shows, I'm probably going to encourage them to go ahead and go with a progestin-based one instead of an estrogen-containing one. Because even if there is, say, a heterozygous factor V Leiden, like, we can't say that that's like the one and only explanation and this patient's not going to get a clot. Like there's still an increased risk. They have the family member, right? So I do it more based on family history. And then, about testing, in the setting of pregnancy or pregnancy planning, I think first of all, it's critical to note that no pregnancy outcome, meaning miscarriage, recurrent pregnancy loss, stillbirth, anything like that outside of the setting of antiphospholipid antibody syndrome, none of those have ever been shown to be improved with low molecular weight heparin, right? So we don't do testing for recurrent pregnancy loss or anything else. Not advisable. In terms of now, do we put the patient on prophylaxis for her risk of blood clot? The guidelines are, there's like, I have like huge tables in all of my papers because I can't remember it off the top of my head. Like this heterozygous, that homozygous, this family, you kind of can look up in the table and say like, okay, well, this might change or might not change my recommendation. But recommendation and management, I love that Anita said management, because recommendation and management are different things, right? Management is our recommendation plus shared decision making with the patient. So if you have a patient, they're like, no way, no how, I don't want to do that low molecular weight heparin, don't open the can of worms. Just like, talk to them about the risks and benefits and let them make the decision. I don't think there's anything set in stone. And so I tend to have like more conversation up front before I do the testing. I think that's actually the time to have the conversation rather than after the results come back. That's my approach.
I completely agree with that. I think that what thrombophilia testing means, and more importantly doesn't mean, is so important to discuss. And the just like facing into it, like this may put a flag on the ground, but it doesn't mean what you think it means. And honestly, what I hear the theme kind of coming up here is the clinical history is more important than the results of some random thrombophilia testing. So let me jump over to Allison real quick. So before we leave this topic, I want to talk about what do we do in the acute setting? Where do folks get it wrong, and where do you, as a strong inpatient anticoagulation steward, intervene the most on this topic in the acute setting?
Yeah, it's a huge challenge and a big opportunity for anti-thrombosis stewardship, because there's such, not just financial implications, but I think even more importantly, such clinical implications, long-term clinical implications for our patients. And so we know guidelines recommend not testing in the setting of the acute event or in the inpatient setting for a variety of reasons, including that these tests can be affected by the acute event. It can also be they can be affected by anticoagulants. And so we really want to defer this to the outpatient setting whenever possible. And like Anita said, it's rarely going to change your initial management anyway. So the way we've approached this at the University of New Mexico Hospital is we've basically taken, heritable testing, Factor V Leiden, Factor II, the endogenous anticoagulants, and we've restricted testing. So providers cannot get this on the inpatient side. So when they go in the EHR and they try to order it, they get a message that provides them with guidance to either contact our stewardship team or our hematopathologist, et cetera. So we can give them the support that they need, but more often than not, those conversations end up being, you probably don't need to test. I think antiphospholipid is a little bit more complicated, and it requires some more negotiation, because there are certain populations in which inpatient testing may be appropriate. I think the big population that comes to my mind is young patients with a cryptogenic stroke. But I think it's important to kind of monitor that through continuous quality improvement and make sure that that is being done in a selective fashion. And I can tell you at my hospital, there's probably a little bit of inappropriate use that we need to examine. But, APS, there's lots of challenges with APS testing. So, for example, where sometimes the anticardiolipin or beta-2 glycoproteins won't be affected by anticoagulants or the acute event, they can be affected by infection and malignancy and pregnancy. So you really want to try to push this to the appropriate non-acute setting off of anticoagulation when you want to repeat test. One last thing I'll mention about APS that people should be aware of is the lupus anticoagulant is affected by all anticoagulants. So you really need to be thinking in the inpatient setting, if this is going to be done, your lab, your special coag lab has to know if that patient is on any type of anticoagulant. If they know that, They can sometimes employ agents like heparinase to neutralize heparins, or some labs have adopted a newer agent called DOAC stop. It's a charcoal-based agent that can arrest the activity of DOAC, so that that lupus anticoagulant can be accurately reported. But all in all, really trying to push this to the outpatient, non-acute setting whenever possible.
Yeah, I completely agree. And I think that APS, that having a little wiggle room on APS also kind of halfway makes sense, because APS for diagnosis requires confirmatory testing anyway, right? And so we have to do some confirmatory testing. I'm going to jump really quickly to it. I could talk about this all day, and I had a couple of other questions, but I want to jump to a different topic as the clock ticks away here. I want to jump over to valvular disease and anticoagulation. I'm going to start with our token cardiologist, Geoff Barnes. A lot has changed with regard to oral anticoagulation therapy in the setting of valvular disease, specifically valvular versus non-valvular AFib, which you'll tell me to quit saying, as well as what we do in the setting of bioprosthetic heart valve. That's really changed a lot. So first of all, if you could talk to us about surgical bioprosthetic heart valves, how solidly indicated is oral anticoagulation therapy in the first place for AVR, MVR? And can DOACs be used as an antithrombotic therapy of choice for the valve, the thrombotic risk of the valve itself, forget about any other indication, in the absence of other indications like atrial fibrillation?
Yeah, so I think this is a great question. And honestly, this is a question that your surgeons are probably managing most of the time. But the answer to that is that there is good evidence to suggest why we might want to consider anticoagulating a patient who has a fresh surgical bioprosthetic valve, either aortic or mitral. And the reason is that the risk of thrombosis is highest immediately after that valve has been placed. It's been estimated to be anywhere between 1 and 1.5% of all patients in just the first 10 days. Then if you go out to about 3 months, it's roughly 5% or so, and then obviously keeps going down from there. And so the way most surgeons are going to approach this is they're going to say, hey, look, if my patient does not have any other indication for anticoagulation, like AFib, like VTE, then I'm going to do some sort of an assessment of bleeding risk. And we know that that's really gestalt driven. But for patients who are at low risk of bleeding, they're usually going to initiate an oral anticoagulant, either a VKA or a DOAC, for usually that first 1 to 3 months, depending on their practice pattern. After that, they'll then put the patient on long-term low-dose aspirin. On the other hand, if they feel like that patient is at high risk of bleeding, somebody with CKD, somebody with a history of prior bleeds, maybe somebody who's chronically taking NSAIDs for some other reason, something like that, then they can go ahead and just use antiplatelet therapy immediately after that valve has been placed. And that is a very accepted approach. So that's the way most people are approaching these bioprosthetic surgical aortic and mitral valves.
The one caveat that I would point out to that is that historical valve guidance treated AVR and MVR differently.
Yeah.
And it recommended anticoagulation therapy in the setting of a mitral valve surgical replacement, and it allowed for aspirin alone in an aortic. But in the most recent valve guidelines, it actually speaks to them the same. Do you know if there's been anything that has changed in either the data or in the valve technology itself that has caused that shift? Or do you think that it was just kind of never based on terribly too much in the historical guidance?
Yeah, I think the way in which we are approaching antithrombotic therapy in general, and especially around valves, has evolved in some regards in relation to really good evidence, and in other times just sort of raising that question, just because we did something doesn't mean we should always do it, right? And I think this is one of those cases where, as we look at the evidence, we say, okay, there is a real risk, but it's not an astronomical risk. We know that the risk of bleeding is important and meaningful. And as we rebalance that, we're sort of looking at it a different way. So I think most patients are still going to get some form of an anticoagulant shortly after a bioprosthetic valve replacement. But the guidelines now support the option of antiplatelet only if you have high bleeding risk.
Yeah, I think it's so important for us to understand, if anybody can read guidelines, what experts do is they understand the why behind the guidelines. And so to your point, we saw this with LV thrombus guidance as well. It was based on like 1980s LV thrombus after, after an MI pre-PCI. That's what it was always based on until recently. So it's so important to understand where the why behind the guideline statements. Now you glossed over there. You said VKA or DOAC, and I can't let you get away with that, boss. Can you explain to me why DOACs are now okay? Historically, that wasn't the stance. What happened?
Yeah, really, I think it's just the fact that one, they have become so ubiquitous as our first line anticoagulant. I mean, it is now every patient starts with a DOAC unless you really can't. And there are some obviously very good situations in which you can't. But I think we've just sort of moved that forward. Patients are now expecting DOACs as their first line therapy. And we have observational data to suggest it's probably safe to use a DOAC in a surgical valve replacement. I think many surgeons may still like the use of a VKA. It's what's familiar to them. They're comfortable with it. But for a lot of patients who don't want the hassle of that, you're seeing more and more DOAC use in this space. And I'm not personally aware of any data of high quality that really says one is better than the other.
Yeah. So for the audience, if you guys want to nerd out on this, the studies to look at, the River trial was kind of, in my mind, the first that said, oh, wait a minute, we can do this. Now, that was an atrial fibrillation population, but what followed the River trial was a trial called the Enable trial, which was the edoxaban trial, specifically in a non-atrial fibrillation population, looking at the question of antithrombotic therapy. And to me, that's what kind of like, put the nail in the coffin of this is fine to do. I'm going to jump to one more question to Geoff in the valve space, and then Tara, I want to get your input on this. So Geoff, the other thing that we see and that we talk about is this question of, and you and I have discussed this ad nauseum. We're probably so tired of answering this question, but rheumatic versus I should say valvular AFib versus non-valvular AFib. And I'm going to take that one step further to really talk about rheumatic versus non-rheumatic mitral stenosis. Can you, once and for all, I know we've discussed it before, but can you fill us in on what's what and what your beliefs are about DOAC use in the setting specifically of atrial fibrillation and non-rheumatic significant mitral stenosis?
Yeah, so it's a great question. So first off, we're going to continue to hear this term non-valvular AFib because that's the FDA indication for the drugs. That's not changing, unfortunately. However, what you're seeing is the guidelines, both the European and the North American guidelines, are all moving away from that term because it's not very specific and really suggesting we should say atrial fibrillation with X, whatever X is, with moderate mitral stenosis, atrial fibrillation with mechanical aortic valve replacement, right? Be specific about what it is that patient has, because that's going to really guide the therapy that then you recommend for that patient. If we're talking specifically about AFib in the setting of mitral valve disease, it's moderate to severe mitral stenosis that we really get concerned about. It's that stenotic element that causes left atrial enlargement and seems to be associated with a higher risk of thrombosis. And those patients were in large excluded from all the DOAC trials. So many clinicians feel like, gosh, I should stay with a VKA instead. My personal opinion is that an anticoagulant is an anticoagulant, and unless we have a good reason that it's not working, like high-risk antiphospholipid antibody syndrome, they're probably all pretty good. But you have to have a shared decision-making discussion with your patient if you're going to do that. So when I see patients who have moderate to severe mitral stenosis and AFib, I have that conversation. I say the guidelines would suggest warfarin is the preferred agent for you. However, if you would prefer not to use warfarin for any number of reasons, it is reasonable then to consider one of the DOACs, recognizing that that is off-label. And if the patient chooses that, then you just have to document that that was the choice. I'd much rather them take a DOAC than not use their VKA appropriately. And so that's how I kind of approach that piece of it. The exact same thing is true in the rheumatic mitral disease space. Again, we're really talking about true rheumatic disease, stuff that we don't see a lot of here in North America and in the United States. But if you do have that true rheumatic disease, the data would suggest a VKA might be better than DOACs. But again, I let the patient really guide this, give them the evidence, engage in that shared decision discussion.
Yeah, absolutely. I think we've now had almost 14 years of experience with DOACs, and there was a lot of stance of, can I use a DOAC? Really, there's two approaches when you have that question. One is, gosh, I can't use a DOAC because I don't know that I can. And the other is, I don't know that I can't use a DOAC, or excuse me, I don't know that I should use a DOAC because, something tells me I can't. And so I really approach it the same way that you do, Geoff. Until I have data that says that, unequivocally one drug does better than the other, I feel like these are, pick and choose. And so there are some settings where we know VKA performs better and where DOACs just shouldn't be used. Mechanical valves, as you pointed out, APS, especially triple positive APS and those kind of things. But short of that, we need to remember that all of this, random stuff is relatively off-label for warfarin 2. And it's just all that we had to use to make stuff up with. And that's essentially how we got here. So Tara, let me jump to you. It's been quiet. I apologize. We haven't had a chance to chat yet. So, in the outpatient setting, like myself, I feel that we often end up having to bat stuff away or have to correct behaviors that we see coming in. So as an outpatient steward, what do you see in the valve space that you have to straighten folks out on, either their understanding or, as Geoff mentioned, he's leaning a lot on shared decision making, and I don't think that we focus on that enough, folks. We work for the patient. Okay, it's our job to educate them and have them make a decision. So what role do you play? And let's be specific right now to the valve, the stuff that we see for valves and how it's changed over time.
Yeah, I mean, I think in the outpatient setting, it is just like you said, it's really important to be the voice for the patient and be their advocate. My job is not to say no, but to look and really think about the information that I have and help them find the right people to have that conversation. Sometimes they are told, no, you can never have that because, the physician that they happen to see or they were admitted, they don't know the change in the guidelines or they don't know the updates in the evidence. So it doesn't mean we can't ever revisit those conversations as more information comes out. And it isn't about, no, you can't, because, to Geoff's point, if they're not going to take warfarin, something is always better than nothing in this space, but we just need to make sure that they're informed of the risks and the benefits of both sides, and then they can make that choice and then we can follow it. And I think, in the outpatient setting, one thing that I really rely on our teams to do, and this applies to thrombophilias, valves, anything, is that we need to be the source of truth when it comes to documentation. It needs to be clear. It needs to be accurate. I find a lot of patients that are on anticoagulation long-term because of a valve. And then you dig and you dig and you dig. And I'm like, oh, you have a bioprosthetic valve and you have actually no other indication to be on therapy for the last 3 years. And I'm glad we've bridged you 3 times.
I hope most of them have 4 valves,
Yeah.
And, and just the prosthetic valve. And I go, okay, like, that's great. Is it bio or is it mechanical?
Right.
Because again, those things make a difference. So sussing those things out and, providing options to patients and then taking a look at patients to say, oh, historically you've been on warfarin because that was the only information we had. But now you can actually be on a DOAC. You are not life sentenced to VKA therapy, and, seeing if that is an option for the patient. And then looking at the aspirin use, like Geoff said, we'll step down some of these bioprosthetic valves to monotherapy aspirin, not aspirin plus anticoag. So if they are on that aspirin, is there an opportunity to deprescribe while they're on anticoagulation and then make the switch if there is a decision point to come off anticoagulation in the future?
Yeah, if I see one more patient avoiding DOAC due to obesity, I'm just going to quit. I just quit. I'm just. I had another thought, and it was brilliant, and it went away. Oh well. No, those are all extremely good points. Oh, I know what it was. We in anticoagulation service do a much better job of putting the story together, because so many of these patients are out there flopping in the breeze with, bits and pieces of their medical record talking about some random clot or some reason they're on a anticoagulant. And I think that if nothing else, we should have in our records very documented, clearly spelled out story of what happened to this patient. And I would argue if you don't have that, then you don't know what you're treating. And if you don't know what you're treating, how do you know you're treating it appropriately, right? So I feel very strongly that we need to be the best at documenting this stuff. All right, I want to jump over to inpatient care. Allison, tag, you're it. We had a lot of questions. This is actually very thoughtful questions about the metrics. So in the outpatient setting, we've talked about warfarin TTR, and we've talked about event rates, and we've talked about all kind of stuff that, you know, kind of typical metrics that we might monitor to determine quality of care. But we had a number of questions about what metrics do you recommend for inpatient acute care setting as it relates to anticoagulation oversight and your stewardship efforts. And I would say that there are really a couple of angles. One is, how do we know that clinically we're doing a good job? But the other part that came out of the questions we had was, how do we justify ourselves? How do we show that we're having a significant benefit to justify ourselves? So what do you think about this?
Well, I think it's one of the most common questions that we get. I will say, I don't know that it's an absolutely easy question to answer, because as everybody probably knows, there are no, you know, federal level mandates or any prescriptive metrics that we're required to follow. So this largely falls on individual institutions or practices to determine what they're going to follow and measure. But I think it's a really important question, because this is exactly what distinguishes and elevates stewardship beyond anticoagulation management, right? We have to be good stewards over the resources and the energy that we're dedicating to managing these high risk but very essential therapies. And so when I think about metrics, in my brain, they fall into kind of three big buckets. The first is for accreditation, right? So the Joint Commission has a national patient safety goal that has two elements of performance, one focused on perioperative management, one focused on bleeding management and reversal. If hospitals want to remain accredited, if they're a Vizient hospital, if they're a Joint Commission hospital, they have to comply with these elements of performance. So that's one big bucket. The second big bucket I think about is, while they're voluntary and they're not mandated at the federal level, there are some quality measures associated with anticoagulant therapy in the form of hospital-acquired VTE and also VT prevention practices that hospitals can opt to report on. The third big bucket is just on the granular hospital level, things like, do we have an issue with financial impact of overuse of high cost, high risk drugs? Do we have an issue with patient safety? Are patients getting harmed in our hospital by heparin infusions on the regular? Things like that. So, Arthur, I hear you say a lot that you're a really simple guy, and I'm a really simple girl. And I try to keep stewardship very simple. And so when I do an initiative, I think about ABC. So the first thing I would recommend everybody do when they're thinking about doing continuous quality improvement is alignment with their leadership. You want to find out, what are your hospital administrators, what are they being held accountable for, and what do they need to answer to their bosses in regards to. So you really want to approach this from a standpoint of help me to help you. And when you get that alignment, then you can move into the next steps, which are B and C, which is build. So you want to start a small pilot initiative, right? With the appropriate people to help you get some baseline data and implement it, let it run. And then C is check. And so you have to make sure that what you're doing is having the impact that you're intending. And so with that, you can take that information to your leadership, which will help you show the value of the interventions that you're doing. And what I will just offer, don't try to boil the ocean. Don't try to create an entire stewardship program all at once. Pick one or two metrics, get some small early wins, string those together, and keep going back to your leadership to say, do you see the value? We're reducing harm events, we're saving money, etc. But this is an absolutely essential component of stewardship. And along with that, we need to be publishing these initiatives, no matter how small. We need to be publishing these to grow this body of evidence to show the value in antithrombosis stewardship.
Absolutely. There's nothing that the approach that I've been taking with that last point there about publishing is that we want to generate referenceable data that can't be ignored. That's kind of the approach that I'm trying to take. We can't ignore this because it is out there in the ether, and it's not just something that we know in our little, inside of our four walls. Bethany, let me jump to you on this inpatient topic. Since meeting you and having you on webinars like this and talking about things that make me blush, my team and I have focused more on women's health considerations, and particularly how anticoagulation therapy may impact menstruating women. Are there women's health considerations in the acute care setting that folks are probably missing or consistently not getting done?
Yeah, absolutely. And thank you for focusing on this topic. We were joking earlier about the little known fact that half of all patients are women. An even less known fact is the uterus doesn't know that it's inpatient, and so it won't hold off on its period. So if you have a menstruating person in the hospital and they're due for their period, even if they're not due for their period, right? It might come early because of all the physiologic stress. So patients have periods in the hospital. Nurses are usually like pretty okay about this. They'll just like get the patient a pad and they might give the doc an FYI. I'll throw my specialty under the bus. Some internists and hematologists will like freak out and call gynecology and be like, "Oh my gosh, there's bleeding." You don't have to do that up front, right? It's good to be aware that patients might have vaginal bleeding and it might just be their period. It's also really good to know that if we're starting somebody on anticoagulation, unfortunately, at the same time, a lot of times the birth control that they were on before will get stopped, and so that will initiate a bleed within a couple of days. And so even if a patient's doing well, they're not in the hospital, they're going to go home and they could have just like a massive period. So at the very least, we need to be educating patients about this, that this is something that they can expect, whether inpatient or outpatient. I always ask when I get notified about a menstruating patient, we're starting on anticoagulation, I always get a ferritin. This isn't guidelines based, this is my personal practice, while they're in the hospital, because chances are they're probably already iron deficient. And if they aren't, they will be shortly. And some institutions, it depends on your institution, we give iron dextran inpatient, so we can kind of get a leg up on that. So those are kind of things about menstruation, talking about menstruation, being aware it could happen in the hospital, checking iron, talking about menstrual management plans, not stopping the hormonal contraceptives if you don't have to. The other reason you can kind of, reproductive age people might be in the hospital, right, is they might be delivering. And this can get really challenging. And different places have different approaches specifically to delivery planning. And so in our institution, we tend to be a little bit induction happy. I think, which I'm on board with because I'm all about scheduling things. And if you can schedule a birth, all the better. But I think most institutions will go ahead and schedule an induction for somebody who's on therapeutic anticoagulation, so you can plan for that. We don't always do it for people who are on prophylactic therapy, but that's something to be aware of, that you're going to need to be planning for that. In somebody who is having an acute VTE event within 3 months of delivery, right? They're having that clot, 35, 36 weeks. That's where it gets really sticky, because it's like having an emergency surgery, right? Like you can't just like hold the baby in for 3 months until the risk decreases. And so that's when you have to get really thoughtful. This is one of the few places where, don't kill me for saying it, Arthur, but we do sometimes consider bridging with IV heparin, because that's the one thing that you can turn off. And even if you do schedule in an induction, you don't know how long it's going to take, right? I was induced, I was in labor for 50 hours. I've heard worse. Like, you can't just let somebody sit for 50 hours without any anticoagulation because you don't know when the baby's going to come out. And so that's something to be mindful of, is that's a scenario when you might have to get more creative.
Okay. Excellent. Really good points. But let me just make something completely abundantly clear, Bethany. If you want to get invited back to one of these, I'm the funny one. Okay. Let's just make sure that yeah. Okay.
Noted.
Okay. Tone it down. No, I'm just kidding. Allison
has a question.
Yeah, I just want to. I have a real quick comment. I just want to give Bethany some props, because I do think you are creating a huge movement in this area. We too have been inspired at University of New Mexico Hospital. We're trying to embed this awareness into our everyday workflows and create stewardship around it. So we do a lot of, our pharmacy stewards do a lot of acute VTE consults, et cetera. And we built in specific interview questions about, have you experienced heavy menstrual bleeding? Are you on anything for it? And what we're doing is identifying these people before we start the anticoagulants to make them aware that there's going to be an issue, but we're getting them in touch with experts like our maternal fetal medicine colleagues so that we can get them, the care that they need. I have been astonished at the frequency with which women tell us, yes, I actually have heavy menstrual bleeding. So I just want to give you a shout out and say thank you for starting this movement, and hopefully we can do a good job with stewardship around that.
Thank you. That makes me so happy. And yeah, a third of women will have heavy periods. It's super common.
Yeah, it's been a whole thing at my facility as well that you've lit a fire under. So thank you, and stop it. No, I'm just kidding. You're doing a great job.
We're taking it to the
Geoff, I think you
outpatient
had some
setting
ideas.
too,
I think you had some.
try to carry through that.
Oh yeah, I'm sorry, Terry. You were saying?
Oh yeah, I was just gonna say, to piggyback, like all of this good work that you're doing on the inpatient setting, like we're trying to push that into the outpatient setting too, because we do have so many touches with those patients. And when you look at the typical intake form for any patient entering into an anticoagulation clinic, this isn't in that, those list of questions to ask, or we're not addressing it up front in patients that are menstruating, and patients that are going to be thinking about getting pregnant. So how do we change the language for our clinicians in the outpatient setting? How do we hit home like the easy wins, like 7-2-1, like making sure we're asking patients like, are your periods lasting longer than a week? Because that's miserable and should happen to no one, and we need to know about it. And are you changing your pad every 2 hours? Are you staying home and losing that quality of life literally because you're just afraid of leaving your house and having a bleeding event? And are you passing those clots that are an inch or like about the size of a quarter? Like those things matter to your patients, so they have to matter to us. And reminding them like you can be on anticoagulation as long, or on contraception and estrogen hormones as long as you're on anticoagulation. We don't have to buy into that myth. Like we can help treat you, and just continue those conversations. When you're bleeding too much doesn't mean you're over anticoagulated, doesn't mean you half your anticoagulant, doesn't mean you stop while you're on your period. We have things that we can do, either changing your blood thinner or your anticoagulant, maybe you're on warfarin, maybe you're on Xarelto, like maybe we can put you on dabigatran or apixaban. What else can we be doing for you? Do we think about other kind of therapies?
And Tara, to your point, also just can we at some point drop the dose of anticoagulation at some point if this is really an issue where the bleeding has not gotten any better despite our other management. So there are options.
There are options, but we don't know it's a problem if we don't ask. So you're absolutely right, Tara. We've done the same thing. We've incorporated some questions into our just standardized note template. It's easy to do, guys. We have electronic health records. You can just copy and paste stuff. It's great. Geoff, I think you had some ideas on inpatient metrics. Like to hear from you.
I wanted to come back to sort of where we started, because I think this conversation for me has really highlighted the double-edged sword that is antithrombotic stewardship, right? The beauty is we can work on so many different problems, and that can really be tailored to our institution, to our population, right? If addressing women's health issues is really a priority, then that can be a stewardship effort. On the other hand, if the interest is really in the high cost of using reversal agents, well, then that can be a stewardship effort, right? And so stewardship is not one size fits all. It's what is important to your institution at this time, tackle that problem, and then move on to the next. And so, you've heard several in the women's health space that can be really patient-oriented and impact patient-centered outcomes. Obviously, we know about appropriateness of DOAC prescribing. In the inpatient side, we obviously think a lot about the nomograms and the correct use of heparin, but think about things like the utility of HIT testing and whether or not people are testing appropriately, and what's the cost associated while that workup's happening of switching people to heparin alternatives, and can you sort of improve on that and help to reduce costs. Some of the outpatient things we think about all the time can also apply in the inpatient setting. So can we work on aspirin deprescribing? Can we work on increasing appropriate DOAC prescribing so that when they transition to the outpatient setting, they're already on the right drug, right? Can we work on some of those elements? I mean, there are so many different things that you can do. You just have to figure out what's important for your population, for your leadership. Allison, I loved your ABC sort of structure, and then start going after that.
And Geoff,
yeah, absolutely.
that just real quick, I think there's a lot of great ideas for quality improvement stewardship, but it's hard to do because you can't do it in a silo, and you have to have those partners in different fields. And that's where it gets tricky sometimes. So you have to find champions in different specialties where these problems affect their, management and treatment. So it is difficult, but it can be just so impactful if you find those people that you can work with and build the B in Allison's ABCs, build that team.
Yep.
Yeah, you mentioned HIT and work around that. I recently actually consulted on a legal case where a young female had a completely devastating thrombotic outcome from HIT that was never caught. And I couldn't stop but think, if this patient had been admitted to Allison's hospital, that wouldn't happen. She would not have had a devastating stroke and be completely debilitated at this point. And it's where she was, the resources that they have, and it just is a call for stewardship across the board. Speaking of Allison, I want to come back to you on, I'm going to stick on the inpatient theme just for a bit here. We had a number of questions about what to do in the acute setting and acute declines in organ function. So we think about, what do we do with cirrhotics and what do we do with patients with end-stage renal disease and that kind of thing in the outpatient setting. But when this represents an acute change, so in renal function, hepatic function, often mostly pronounced in the acute care setting, what is your approach to anticoagulation management? What do you do in that setting? And I might specifically, if we're going to talk about hepatic, specifically call out like acute hepatic failure in a non-cirrhotic versus, say, an exacerbation of cirrhosis. What is your approach?
Yeah, so I mean, this does happen a lot in the acute care setting, and it's particularly challenging when they happen at the same time. So we don't like that situation, but sometimes have to deal with that. I guess let's break it down. So let's just start with renal. So when somebody comes in an acute renal failure on therapeutic anticoagulation, the first thing that we think about is, what anticoagulant is the patient on, and how is this acute insult going to impact that therapy, right? And so if somebody comes in and they're on something that's not heavily renally eliminated, like warfarin or even apixaban, right? Because we're using apixaban more and more in severe renal impairment. We may not have to make any big changes, but let's, take somebody who's on therapeutic enoxaparin or dabigatran, which is heavily renally eliminated. That's probably going to require some changes in therapy. And so the other thing we think about is, why is this patient presenting to the hospital? Do they have a big bleed because they accumulated their anticoagulant? Because we're going to need to intervene there. So I think, a lot of times we also think about, why is this patient on anticoagulation? Is this insult something where we can just withhold the anticoagulant for a brief period of time, like an AFib patient with a low CHA2-VASc while they ride this out? Or is this like a patient who was in my emergency department 4-5 days ago with a PE that absolutely needs to have their anticoagulation continued? And so in that situation, if the renal impairment is severe enough, we're going to have to reach into our toolbox and pull out the most appropriate therapy. And, Anita mentioned Stefan Mall earlier, and I think a lot of us have heard him talk about the warfarin hate factor. I would offer that a lot of us inpatient clinicians have a huge heparin hate factor, but it's an important tool in our toolbox. So sometimes we do have to lean on that agent. I think in regards to severe hepatic impairment, I think this is much more concerning, at least from my standpoint. I'm very interested to hear what others think, but, we have some evidence that, DOACs might be okay in chronic hepatic impairment up to, in cirrhotics, a child's PUB. I don't know what that looks like in the acute on chronic setting, so it makes me very nervous. Apixaban is like mostly hepatically eliminated, so that makes me nervous, and I tend to gravitate to other agents. We love to use enoxaparin whenever we can if there's preserved renal function. If not, we have to rely on heparin. But I will say sometimes the patient's the hepatic impairment is so severe, it's going to really limit our choice of anticoagulants, right? So you think about warfarin, it's not going to be metabolized, and the INR is going to be deranged from the underlying disease itself. So warfarin's kind of out of the window. I'll also point out, we had a patient the other day that came to us in septic shock, severe hepatic impairment, and bilateral PEs that we needed to anticoagulate. We were heparinizing him and we couldn't get him to therapeutic, so we checked an antithrombin level, undetectable, because his liver wasn't making antithrombin. So we had to get very creative and give him some exogenous antithrombin to keep him anticoagulated, et cetera. So it can be very complex, and there's lots of considerations that go into which anticoagulant you're going to choose in an acute setting for your patient.
Yeah, I'm going to jump to Anita there and get some comments on that from the inpatient setting as well. And specifically, certainly any thoughts you have on this, but also, are there other acute conditions that might impact treatment decisions that I'm not thinking about as an outpatient guy?
Yeah, so just to speak to Allison's comments, you know, I think you have to think about all those points. And I like to think about, is this acute liver failure, renal failure, is that going to get better soon? Do we know exactly what the cause is? And, you know, within days, like if there is some obstruction of the urinary tract system and that's being resolved, like that's going to get better, then I get nervous about, you know, switching anticoagulants and having subtherapeutic levels and then peaks. And so, you know, in those patients, I might just kind of ride the wave for a couple of days and really make sure the organ function's improving. The ones that I get nervous about, like you were mentioning, Allison, are those acute liver failures, especially because there is a very high risk of bleeding in those patients. I mean, they have low fibrinogen levels, they have low platelets, there's a DIC component. And so we really need to be careful in those patients with severe liver failure. To your other question, I think, Arthur, you were mentioning about where there might be some conditions where we prefer certain anticoagulants versus others. In the outpatient setting, what I think about mostly is antiphospholipid syndrome. And we've sort of touched on that. You know, DOACs, I feel like everybody's on a DOAC now compared to warfarin, right? But there are some specific areas where we need to be careful. The data seems to be showing us a concern for antiphospholipid patients who have arterial thrombosis. So, you know, your stroke, your peripheral arterial embolisms, and as well as triple positive. So those patients that are the highest risk for recurrence, and especially those with lupus anticoagulant. So those are the patients where I shy away from a DOAC, because there are some decent data and more is emerging that there's a high failure rate with DOACs.
Mm-hmm.
Excellent points. Let me jump, and we have a few minutes left here for discussion, and we could talk all day. Let me jump over to the outpatient care setting, and those of you who've known me for a while, you know, and you mentioned it, Bethany, you know how I feel about periprocedural bridging when warfarin is interrupted. I personally hold a strong belief that bridging is arguably never solidly, absolutely indicated. We can arm wrestle over this if you want. It's something to consider, to let patients make informed decisions about in certain higher risk situations where we give them the good, the bad, the ugly about it. Yet there remains this pretty wide sweeping assumption that mechanical valves represent an absolute indication, no questions asked, they have a valve, we have to bridge them. So Geoff is a cardiologist and an anticoagulation expert. What can you fill us in on your stance on this and specific to kind of mechanical valves?
Yeah. So this is interesting, right? The data, the prospective high quality data would clearly state that there is not benefit from bridging and that there is real and measurable harm, even in patients who have mechanical aortic and mitral valves, right? We saw that in the PERIOP-2 study. The problem is it was a relatively smaller part of the overall population. It wasn't only focused on that. And we have to understand just the psychology of who we are as individuals, right? We were all trained to bridge. And so changing our behavior is a really big lift. And without very explicit, high quality data really being, pushed at us, we tend to fall back on the things that we're most comfortable with, which are the things we were trained to do. The other piece of this is that as clinicians, we always feel responsible if we withhold therapy, but less responsible when there is a side effect from a therapy that we can otherwise justify, right? So if I don't give somebody bridging and they have a thromboembolic complication, I feel ownership over that. But if I bridge them and they happen to have some bleeding, well, I had to bridge them anyway, right? I'm not saying it's right, but that's the psychology of what most clinicians are thinking about. And so I think it behooves us to keep that in mind and say, okay, how do we just step by step move this forward? We have made incredible strides in reducing the use of bridging in AFib and in VTE, and that should be applauded broadly, right? So the next step is to go one step further and say, okay, how about your low risk mechanical aortic valve patients, right? And so we're starting to see a little bit of movement in that space. It's going to take time for people to get comfortable with that, people to get used to it. Hopefully more data will be generated. Once we get that foot solidly landed, then we'll be able to go to the next one, which is the mechanical mitral valve replacement, right? And so we just have to accept that this is a slow moving process unless somebody wants to run a 1,000-patient randomized trial only in mechanical valves.
The moral of the story there is Geoff is far more patient than I am. That's basically what I think he just said. Yeah. Go ahead, Allison. Tell us how this affects the inpatient side as well. Yeah.
Well, on the inpatient side, I think, we try to empower the clinicians that are involved in managing these patients. So particularly our cardiology pharmacists, our antithrombosis stewards, and our clinic pharmacists that are developing these perioperative plans. We try to empower them with the knowledge, like from the PERIOP 2 trial that Geoff mentioned, not to be overly dogmatic, but to let them know that there's room for discussion with the people who are doing the procedures, that they might not have to do therapeutic bridging. The point I wanted to make is anytime we're choosing to not therapeutically bridge somebody, or we're withholding therapeutic anticoagulation for whatever reason, it is really important in the acute setting to provide evidence-based VTE prophylaxis to prevent hospital-acquired VTE. So please don't forget that.
Yeah, the outpatient equivalent to that in my mind is patients going in is a fibber on anticoagulation therapy going in to have a complete or a total hip done. When I say the patient doesn't need bridge therapy for his thrombotic risk, that doesn't mean he doesn't need VTE prophylaxis appropriately following a very high risk procedure. So that's an excellent point. All right, Bethany, last couple of minutes here with regard to bridge therapy. Are there caveats in females that we may or may not be thinking about, pregnant, not pregnant, menstruating? Any caveats that we need to cover for women's health?
Yeah, I would say the main one is really, again, those kind of 11th hour VTE events in a pregnant patient. Labor, occasionally you'll have a scheduled C-section. Great, then you can plan that like any other surgery, right? But if you're talking about like a delivery that's not a planned C-section, right? If you're holding like 24 hours prior, and then they're in labor for 2 or 3 days, and then if there's a C-section, and then there's postpartum hemorrhage, which happens in like 4% of patients, whether or not they're anticoagulated, and then you're delaying. I mean, you could easily wind up with somebody off of anticoagulation for 4, 5, 6 days. And so in a scenario like that, and somebody who's had a recent VTE, and somebody who, maybe they had a PE that affected their hemodynamics, that's when you want to be thinking about like, okay, what agent can we keep on for the longest period of time and stop as quickly as possible? And again, that's why that kind of unfractionated heparin comes into play. It's also, the other nice thing about unfractionated heparin is I always really strongly advocate for patients to be able to have epidurals, even if they say they don't want an epidural. Like if you want to be awake to see your baby and you have to go to a C-section, you're going to want an epidural, right? And depending on your anesthesiology service, like maybe you can turn that anticoagulant off, get the epidural placed, maybe go back on some form of something, and then stop it before you pull the epidural catheter out, right? So those are negotiations to have on a case-by-case basis. And the other thing that I always, people are always kind of surprised by, right, is the risk of a VTE in the postpartum event, in the postpartum setting. So 6 weeks after delivery is the same as the risk during the entire 38 weeks that somebody is functionally pregnant. So the daily risk is actually higher in the postpartum setting. The OBs I work with are really excellent about getting that, the anticoagulation on. I think OBs in general are more comfortable with bleeding than probably most of our surgeons. And so they're pretty good about that, but make sure that you're talking to your OBs about like, okay, it's been 24 hours. Do we feel comfortable? Can we start something prophylactic? And then try the therapeutic, like how can we get this on as soon as possible?
All right, Terry, you have a quick thought?
Yeah, I was just going to say real quick, in the outpatient setting, I think it's important to ask the questions, or like, pose the plan to the provider in the way that they need to hear it, because most of them don't keep up with the guideline recommendations. So they say, my patient has historically always bridged. So we say, your patient's going for this procedure, here's their thrombotic risk, here's their bleed risk. Based on guideline recommendations in these studies, we recommend not bridging your patient. And 9 times out of 10, probably 9.9 times out of 10, they're going to say, oh, okay, great. Because they're not going to come back and say, I don't agree with this study, or I don't agree with the guideline, unless they have a real reason. Like, my patient almost died. This was a life-threatening clot. And, highlighting too, like, the first time they might have gotten the bridge plan from you might have been 4 months after the clot. And now you're sending them another bridge plan 4 years after the clot. So the situation has changed. So maybe the plan has to change.
Yeah, and medical science changes too, people. It does. It advances. Yeah. So, all right, we've come to the end of our time together, guys. I love these conversations. I think you were all some of my favorite people and smartest folks on this topic. I've really appreciated the opportunity to speak and with all of you and to address these topics. We'll have to do it again. I want to thank the Anticoagulation Forum again for setting up this awesome opportunity for us to just chit chat. And we look forward to seeing you on future webinars and at the DC meeting. So thanks, everyone. Enjoy.